Hello, we're going to talk about SPECT-CT in tumours and how we can use this technique to improve our oncological imaging with single photon techniques. Talk first of all about the advantages of SPECT and why we would then move on to hybrid images using SPECT-CT, and looking at some of the specific uses of SPECT-CT in somatostatin receptor imaging, a little bit on MIBG, a bit more on SPECT-CT in sentinel nodes, and to finish off, just some mention of its use in prostate cancer. Actually, missing from the list is we'll also be looking at iodine-131 post-therapy. So why SPECT? Well, that increases the contrast between the target tissue and background and separates overlying layers. We can add CT, which helps us improve our localization. But we do have to remember that the spatial resolution of tomographic imaging is worse than for planar. I often show this example. This is a patient with a whole body scan following indium 111 pentetratide or octreotide. And all you can see is the normal distribution of kidneys, spleen, and bladder. However, when you do a SPECT study of the upper abdomen, you can also see that just in front of the spleen lies a small focus of uptake, which is a tumour in the tail of the pancreas. So the next step is to add this to CT, because it enables us to localize any uptake more precisely and improve specificity. And this localization can help to identify particular tumour sites, which may be example for useful for surgeons for sentinel node studies. Generally, CT machines and the tracers are cheaper than used in PET. So this patient was imaged without a SPECT-CT. They had a CT scanner scanned on a standard CT scanner, and then they had a SPECT study done. And then using a software approach, mainly fixing the renal activity, you were able to register the SPECT image over CT, and you can see very nicely a number of liver metastases. Moving to dedicated machine, this is one of the first patients that we ever did on the machine we had in London. And when you look at the low intensity picture, you see nothing, but on the high intensity picture, there's two areas of focal uptake in the pelvis. Now, one of them, the top one, you think, well, that might be something, and the bottom one, maybe just urine. But with SPECT-CT, we can indeed see that the upper one is, in fact, a right-sided external iliac artery node, iliac artery node. And that's as expected. But what was not expected is when we looked at the lower area of focal uptake, which most of us thought to be urinary, there was in fact uptake in a small lytic bone lesion. So this suggests that we may not just improve specificity, but sensitivity using these techniques. Now, this is a nice example where it does improve specificity. So here we have a indemocratized study, a tomographic image. We can see the uptake in both kidneys, and this sort of uptake anterior to that looks a little bit like the colon. And by 24 hours, we often do see normal colonic activity of this tracer. But with SPECT-CT, we can see that this localizes not to the colon, but to the peritoneum. And these are, in fact, peritoneal metastases. This is a patient I'm going to show you two pictures of. The first one is just of the skull, and you can see this unusual uptake here, just behind the orbit. And this is in a metastasis in the eye muscle. It's very important these are removed, otherwise the optic nerve could be damaged. But on the same patient, down in the pelvis, we could see there was some low-grade but definite uptake in the right ischium, which represents a further bone metastasis. In terms of data, most of the work was done around about a decade ago. Quite small series, this one by Wong et al. From the US, looked at 49 patients and compared SPECT indemocratide with SPECT-CT. And they found that 28% of the lesions identified as pathological on SPECT were in fact found to be just normal physiological activity on SPECT-CT, mainly within the gut. SPECT-CT changed the patient management in about 24% of patients compared to only 14% with SPECT. And they said they felt that this is because the confidence in reporting was improved. This is a further piece of work that was done in Italy, looking at different sites in 81 patients and looking at where there is an improvement between SPECT and SPECT-CT. And you can see that in most areas there's an improvement, possibly less so in the liver and the lung, but certainly in pancreas, significant improvement, though still not 100%, because quite a lot of pancreatic tumors don't express the right receptors. But you can see in gut and lymph nodes and bones a significant improvement, partly because you can localize the uptake and be confident in your reporting. Now, whilst that's indium octreotide has been the one that we use primarily, indium is expensive and difficult to get hold of. So most centers are now moved over with single photon imaging to a Hynek Tate labeled with Tc-99m. And this has increased uptake in somatostatin 2 type tumors. It is a bit cheaper, has a lower radiation dose, and it's now very widely available. And as I said, if you don't have gallium-68 dotatate available, it's a very good solution. So here we have a patient who is 64, no previous history of cancer, but started to get symptoms of carcinoid syndrome. Ultrasound suggests the patient had multiple liver metastasis and had a biopsy performed which showed a G2 level neuroendocrine tumor, moderately differentiated. So this patient had a Hynek Tate study done, and you can see here in both the coronal and the transverse slices multiple areas of focal uptake within the liver consistent with multiple liver metastasis. Now, you may also see that there's some uptake in the abdomen, which is not in the liver. And when we look at this more closely in all three planes as well as CT, this almost certainly represents the bowel primary. Now, what's interesting is that the Ki-67, which is a marker of tumor proliferation, was much lower in the primary than in the metastasis, suggesting that there had been some kind of genetic change in the tumor between the original and the metastatic tumor. And again, this is not surprising. Often metastatic disease is more malignant than the primary. Other areas that specific tumor agents have been used is in things like MIBG for neuroblastoma and pheochromocytoma and paraganglioma, and other peptides such as glucagon-like protein for pancreatic neuroendocrine tumors. So this is the SPECT-CT of a patient with a pheochromocytoma. You can see a small residual mass very nicely on the CT. The nuclear medicine study doesn't look particularly interesting, but when you combine the two, you can see that there is indeed uptake of what is a small amount of residual tumor. Now, this was performed after an adrenalectomy, but clearly the surgeons needed to go back to remove that last bit of tumor. This is a MIBG whole body image in a 15-year-old male who presented with a mass in the abdomen that was painful, thought to be neuroblastoma, but and so we did an MIBG study. They did indeed confirm uptake of MIBG. The only thing is that pathologically it was found to be a paraganglioma, which is probably the better of the two to have, as it tends not to metastasize as much. Glucagon-like protein is another tracer that was used about 10 years ago in a joint project between London, Freiburg, and Basel. Panels A and B are negative studies. C shows focal uptake in the body of the pancreas, and D shows focal uptake in the head of the pancreas. C and D are both insulinoma patients. So about thyroid cancer, well, we can use iodine-123 or iodine-131 SPECT to localize disease anywhere we wish to. SPECT-CT will help with localization, and it may be used post-therapy for dosimetry. I haven't really got an example with iodine. I'll show you an example with MIBG, which is the same isotope, so it's similar platinum. Obviously, if you don't have FDG and it's thyroglobulin positive and negative on the iodine scan, you might want to consider doing a MIBI or tetraphosphamide with SPECT-CT. So our friend Wong, again from the US, looked at SPECT-CT with post-therapy iodine-131 in 48 patients. And they found that in 19 patients, the SPECT-CT really helped, particularly in showing uptake was physiological, not pathological. But in more advanced patients, it found additional sites of disease. So this is a patient we sort of expect to see where we have uptake in the thyroid bed. The patient's had a thyroidectomy. They have about 5% of their thyroid remaining, and we ablate that with radioiodine. So far, it all looks very good. The whole body confirms that it looks fairly good, with majority of the disease on the right side, as we saw in the SPECT study. Fortunately, we didn't leave it at that, and we did this sort of high gain study. And the reason we weren't entirely convinced that we had not missed anything. And in this fairly early stage disease, we found in the thoracic spine small area focal uptake, which corresponded to a lytic metastasis. So this patient went from a stage 1 disease to stage 4. So this is with MIBG, but it's a similar kind of process that's now been done, in that fact that we can do patient-based dosimetry by using the mixture of tomography and scatter and correction to ensure that we get much more precise localization of the uptake, which then enables us to do dosimetry. So here you have an isodose contour around uptake of iodine 131, in this case 131 MIBG, but this enables you to do an isodose calculation, which first of all makes sense to a radiotherapist, and secondly enables us to ensure that we can work out, in this particular case, we had delivered 2 gray of radiotherapy to that tumor. The central node theory of Cabanis and Morton is that there is a logical flow of lymph from around a tumor, and this drains initially to one node called the Sentinel node, Sentinel being American for a guardsman, and then to second and third order nodes. Now, if there is no tumor in the first node, the Sentinel node, then there won't be any tumor beyond, and no further surgery is needed. So they would inject a substance near the tumor that's carried to the lymphatics up to the lymph node. They track the agent and try and find the draining basin, and then they look more carefully and try and remove any nodes. If it's negative, they don't do any further work. If it's positive, then they surgically clear that draining basin. So the first agents used were methylene blue or vital blue dye, depending if you're European or American, injected 30 minutes before surgery, and then they tracked the lymphatics and the draining basin visually, and those that were the bluest, they removed. And this had an accuracy of around about 80%, which, to be honest, is just not sufficient for this kind of problem. So in the mid-90s, people started to use radiocolloids injected just under the skin, or peritumorate. Again, it took about 30 to 40 minutes, for example, in the breast to get to central node. And you could track that drainage with a gamma camera and then in a handheld probe in the operating theatre, where the hottest or most radioactive node be removed. And this increased the accuracy to well over 90%, in fact, well over 95% by Veronese in Italy and Gillette in Australia. Veronese working in breast, Gillette in melanoma. So it's a multi-team work. So the surgical team are involved in selecting the cases. They do the intraoperative probing. They may remove and tag any nodes they want, and they may be involved in injecting the radiotracer. Nuclear medicine, we sometimes do the radiotracer injection. We perform imaging. We mark on the skin where we think that the central node is, and obviously we need physics to help us with our probe. And pathologists obviously look at the specimen and decide whether or not there is or is not tumor. So where do we inject? Originally, people injected peritumorally, but more recently, people have preferred the injection subdermally, and that's the technique that we normally use. This is a breast study, and you can see there are 2 pictures. The one on the left, the transmission. We've got a cobalt flood line behind the patient to give us the outline of the patient. It's got very low energy, so patients attenuate it very nicely. You can see the big blob is the injection site, and then next to it is a little blob, which is a lymph node. And this is the lateral, where you can see that lymph node a little bit more clearly, lying just behind where the first injection was given. In terms of probes, we tend to use these handheld probes. These days they're Bluetooth, and they can be wrapped in a sterile bag so that the surgeons don't break them, drop them, lose them, but they can be used for finding the sentinel nodes intraoperatively. How can SPECT-CT help in this situation? Well, to be honest, it's only really helpful where you have a variable drainage, which isn't really the breast, but it can be helpful in the trunk and in head and neck cancers, either primary melanomas or primary head and neck tumors. And I'll show you some examples. So here we have a melanoma on the ear, and this has been injected. And you can see that just by the primary, there is a sentinel node. This is in the anterior cervical chain, level 3 node. And this kind of image, 3D image, really helps the surgeon know where to operate. There is a new agent coming around called tilmanocept, and this is a mannose receptor agent. And it's mannose attached to a dextran backbone, and then to this is attached DTPA, which complexes the technetium-99m. Use a similar amount of activity as we use for the colloids. But it runs much quicker because it's a much smaller molecule, and because it involves active localization of the lymph node, you get very little stuff passing through the lymph node. So you can see here very nicely in this floor of the mouth tumor, you can see very close to it in the submandibular nodes. There are 2 sentinel nodes seen here on the coronal and the sagittal slices. This is one of our patients with tilmanocept. This patient actually had a melanoma here on the forehead. And you can see that there is, that's the CT. If you look at the SPECT-CT, that's what the primary injection is. And there are sentinel nodes bilaterally, again, anterior cervical nodes. So this is both of them are level 3 nodes. But this kind of information is absolutely essential to help the surgeon to remove all the sentinel nodes they can. So we're going to finish off looking at prostate cancer. We can label prostate cancer with PSMA, and that itself can have a radio label, either more traditionally gallium-68, but where PET is not available, you can't get hold of gallium-68 or any of the new fluorinated products, there is the possibility of using technetium labeled PSMA. Now the resolution is less, and you're going to miss some small tumors, but for most patients with fairly significant disease load, the technetium PSMA is quite sufficient. I'm going to talk a little bit about Bombesin in a minute. So this is some work from Pretoria. You'll see quite a lot of stuff from Pretoria here. And this is looking at the sensitivity of Hynectate as a whole body imaging agent versus MDP versus gallium-68 PSMA. And what they came to the conclusion is, not surprising, is that the technetium wasn't quite as accurate or sensitive as the gallium-68 PSMA, but it was better than bone imaging. And certainly would find enough disease if you were thinking about treating with lutetium. So Bombesin was originally found in frogs. It's a frog product, 14 amino acids. It adheres to the gastrin-releasing peptide regulator protein receptor, the GRPRR snazzy, isn't it? This is found in the pancreas, upper GI tract, and in some tumors, including prostate cancer. Has been labeled with various radioisotopes, but most of the work has been done with technetium-99m, and most of it has been on rats. So this is the structure of Bombesin. So you can see it's a simple polypeptide. This is some animal work with an injected tumour, which is marked TU. And you can see low-grade non-homogeneous uptake within the tumour, whilst there's normal uptake seen within the kidneys, pancreas, and a bit of the liver. Really, most of the development has concentrated on PSMA, so not many people have continued to develop the Bombesin at that moment. So in summary, single photon imaging in cancer is not dead. There's many uses for it. It can be cost effective because the tracer and the camera is less expensive than PET-CT. And in some areas, such as sentinel node, there really isn't a sort of PET equivalent. So you're really stuck with a single photon and SPECT-CT. But it is all getting a little bit more technical, and soon we'll be able to do things like dosimetry and patient-based dosimetry based on SPECT-CT with good, accurate localization and uptake. So the SUV SPECT-CT is getting almost as good as the SUV PET-CT. And with that, I'll leave it. Thank you very much.